41-year-old woman who underwent an endoscopic sleeve gastroplasty. So today she's coming to us for a GEM procedure. We start with a pyloric sparing ankylomyotomy. Follow that up with the gastroplasty, creating a mucosotomy, entering the tunnel, a myotomy extending up to but sparing the pylorus there in the center left. And then you see the actual myotomy, followed by closing the mucosotomy, creating a running suture to protect that closure from the tension, and then completing the gastroplasty.
You can see here we have several tissue bridges, and there's probably at least 5 of these. But here we have gained access. Little
Chris,
trick. Yeah.
This is Dennis. Can you comment on the length of the myotomy for this type of procedure? Aim towards a full thickness, or do you kind of just do it more selectively?
Generally, the myotomy is at least 12 to 15 centimeters in length. This one's pretty long. It's over 10. It's shorter than we normally would do just because of the prior suturing. We try to do partial thickness now, as you can see here, and we try to do at least 2. And you can see it gets really thin right there. We didn't really cut that. It's just we got down to the serosa and it opens up with positive pressure. So we try to do partial thickness. Whereas when you do this, if you just do the myotomy and you don't suture, people wake up and feel like nothing happened. Like they're comfortable, they can go home right away. It's fine. What we'll do is we'll suture that closed, and we're going to take down a couple of these tissue bridges. We're using scissors. Go ahead and cut. And we'll do one more. There you go. That's what it looks like. It frees up. The stomach opens up a little bit more. So we do one very tight suture between at the end of the body, but just before the antrum, right in there. So that's our opening. And so we do a running suture, an interrupt, then another running, and now we're going to be doing another interrupted. Kind of a help with interrupted sutures that we're running. It gives your sleeve a certain shape as well.
You want the suction back down?
No, I think suction will
You
go.
want to keep the air up?
Yeah. So we kind of know we're kind of coming into here now. A little tricky, but you get down in here right there. And then I don't think they're hurting as long as they're not in the way. That first one was just going to be a bugger. It's kind of right in our way. There we go. See, our sleeve is forming on the right, and we're doing a series of running sutures on the left on the greater curvature to bring that in and reduce the width and shorten the length of the stomach. Again, we'll show this cinching process. So I'm pulling on the suture, all right? And he's using his right hand to keep that catheter out so it doesn't come back. And then he's using his left hand to keeping it very straight. And what he's going to do is there's a little, that grasper looks like a biopsy forceps you'd open and close. When he pulls that together, he's jamming a post into a cylinder, trapping that suture and cutting it. Again, he's keeping it very straight. Here he goes.
This is the finale of the case that he did.